Okay, well, why don't we get started? I know people will continue to trickle in, but welcome everybody to our third lecture in our series on aerodigestive multidisciplinary pediatric care. Today, we're very lucky to have one of my colleagues here at UCSF, Fernando Ureggo. He is in the Department of Pediatrics in the Division of Pediatric Pulmonary Medicine. And he's a dear friend and colleague. We've been working closely together in the aerodigestive clinic where we treat patients together for the last year and some change. His expertise includes treating patients with asthma, lung prematurity, cystic fibrosis, wheezing, and chronic cough. He also cares for our trach population and those who depend on a ventilator at home, which is something that is a fairly large part of our practice here in California. His research interests and academic focuses have been on quality improvement in patient care and addressing health disparities. He earned his medical degree in Bogota, Colombia, and completed residency at the University of Tennessee in pediatrics, followed by his fellowship in pulmonology, pediatric pulmonology at the University of Miami. And he also has a Master of Public Health degree from Tulane University, which is in New Orleans here in the States. So thank you so much, Dr. Ureggo. I'll hand it off to you to talk about your role and how we all interconnect with Aerodigestive Clinic.
Thank you, Leah, so much. And thank you for the opportunity to speak today. It's always exciting to be able to talk to people from all over the world. So I'm super excited. Thank you to Mending Kids for the invitation. Thank you, Leah, and thank you, Fiona. And I know that I'll be talking to a lot of surgical specialties. And so some of what I'll discuss is really what happens from a medical perspective. So I hope I don't bore you, but hope we can get through this and then have some time for a Q&A. So we tried this before. There we go. So sort of an outline. I sort of want to give an overview of what the status of aerodigestive centers are around the world. So my understanding is the people that are on are interested in building an aerodigestive center, and so want to learn about what are the bricks that you need to put to build it and to make it a successful center. So I'd like to go over that more so to emphasize the importance of pulmonologists, right? Because this is entirely from a perspective of what I do. So why are patients referred to an ADC center from my perspective? Although the take home is we work as a group. We all try to get our own specialties on the same table so we can treat the patient appropriately. So we'll talk about how to approach chronic cough, and then I'll spend some time about what we're doing with bronchoscopies. So what is the purpose of an aerodigestive center? And I'm like the fourth in this series, so you guys have probably heard this, but it's really to provide coordinated interdisciplinary care to kids with complex disorders. And to do it consistent, effectively, and cost efficient. And I sort of put here a bunch of pieces of a puzzle that are not together. And so the purpose of an aerodigestive center is to try to piece the pieces of the puzzle together to make things work. So there are many aerodigestive centers around the world. I put some of the ones that I found that they've published what they've done. So I sort of, if you're interested in building your own, it's always nice to know, well, what have other people done and where have they been successful and where have they failed? So that way you don't have to reinvent the wheel. But what I'll say is every center has its own sort of nuance. Some centers, the lead is ENT, in some centers the lead is GI, very few centers the lead is pulmonary. But that's an important thing to think about because that oftentimes will sort of dictate what kind of patients you see, the population that you see. Also, when thinking about different centers around the world, resources are different. So what people have access to is different. So we may not all be able to build a comprehensive center, but what I hope to prove at the end is that you don't need all the bells and whistles necessarily. You just need a few people that are interested and passionate, and you can make things work. So I'm going to talk about a couple of these. So this is a center in Israel. They published
Something went wrong. Please try again.
My Siri's turning on because he thinks I'm talking to it. So it published on their first 100 patients. And in their center, the most common reason to get referred was for a chronic cough. And then as you see here, in their cohort of people, most of them had some airway, GI abnormality. So most of these centers and most of the centers that are currently seeing patients tend to see very complex patients, but they don't all have to be sort of multi-complex and have surgical disorders. That many of them have medical disorders that we need to address as well. The folks in Australia published a couple of years ago on 56 of their kids, all of them presenting with a wet cough. And in their cohort, now again, most of them had a TEF, some of them had CDH. So these were the cohort that they saw. Many of them have had bronchiectasis, and most of the common findings that they reported were tracheomalacia. So it really, each country has a different flavor of what they see and what they end up doing and who gets referred to them and who they accept. The folks in Brazil published in last year on 25 of their kids, and their presenting symptoms were more from a GI perspective. And their paper and their group focused predominantly on feeding disorders. So you've had input from all the groups so far, and you'll have a few in the coming weeks. But this just goes to show you that you can build it your way, right? Depending on the resources and who the interested parties are. So I just picked one of the centers here in the U.S. This is the group in Washington, D.C. They published 55 of their patients. Now, again, I'm highlighting the common reason for referral is cough because I'm a pulmonologist, right? And that's my comfort zone. Most of the kids that they saw had a cleft. Many had large adenoids. And their paper says 70% of the people they took care of were much better after having had an aerodigestive evaluation. So what we're doing and what people do in their ADC center is really making a difference and is helping people. So many centers that I just sort of shared with you have different sort of points of view and how they address things. But all centers have something in common, right? All of them have an interdisciplinary medical team and a surgical team. They'll have ENT, pulmonary, GI, nutrition, speech. Many of them have social workers and patient navigators to help sort of coordinate everything. Most of, or everybody should have sort of huddle where they look at the patients that are being referred and decisions are being made as to who are they going to see and what's going to happen afterwards. But ultimately, most of the patients that get referred to an ADC center get triple scope. And that's because we're all proceduralists, right? And so if you're a hammer, everything's a nail. If you're a surgeon, everybody that's going to come in needs to go to the OR. But that's not everybody. So not everybody who gets referred to an ADC eval necessarily ends up with a triple scope. So this is from a study that looked at cost, but I took their sort of table in terms of what is the usual flow of an aerodigestive clinic, and this may be different wherever you are, depending on the people that are involved and the resources that you have. But I chose this one because it mirrors the center that we have here at UCSF, where patients are referred mostly by either the pulmonologist, the ENT, or the GI doc. And then we see them and talk about them as a group. And then we ultimately make a decision whether they need to go to the OR or not. But the point that I want to make here, and the point that I think is important when you're thinking about, starting an aerodigestive center where you are, is you need to really think about other referral sources. So the pediatricians, the NICU, the ICU, really need to work on these people also feeding your clinic, so you can see the volume and your group can become good at what they do. So to that end, there's an aerodigestive research collaborative referred to as the ARC, which is 8 centers here in the US that are sitting around a table and saying, all right, we have a lot of AADC centers around the country, and many are being developed around the globe. And in order for everybody to be on the same page and everybody to sort of have consistent care, these folks are sort of looking at ways that things can be standardized. So they've published on their intake questionnaire and their triple endoscopy elements. And I understand that their clinical eval is going to be published soon. But the point that I wanted to make about this slide is, in order for everybody to be successful in a consistent way, we all should be thinking about doing things consistently, right? So it's interesting, in their intake questionnaire, they took a lot of questions off, which I thought would have been important. So their guidelines will be important to standardize aerodigestive centers here in the US and internationally, but you always have to make it fit to where you are. And what they publish about sort of their triple scopes from a pulm standpoint is we should all be reporting tracheal Malaysia in the same way. We should be looking at our bronchoalveolar lavages in the same way. So I suspect this group will have a lot of interesting data in the future to help all the other centers. So that brings me to, cough and what is my role, what is our role here. And, cough is the most common complaint in pediatrics. It is what most general pediatricians will see. There's a big financial burden. There's an emotional burden. So obviously from the pulmonary standpoint, cough is a big deal. But from an aerodigestive center, as I just showed you, most of the patients that are being referred have a chronic cough for a number of reasons, but that's sort of the presenting symptom. So I used to have a slide where it was a kid who was coughing up a lung and a stomach and all the guts, but I lost that slide. So I have an old man farting there. So there are cough guidelines in pediatrics that are very different than cough guidelines in adults. So the group in Australia has really led this. So Dr. Chang and her group published cough guidelines in peds in 2006, and there have been several iterations of it. The last one was in 2020, and different countries have different guidelines. But they all sort of approach things in the same way. And so I'm going to share with you from a pulmonary standpoint how we think about cough. Most of the time when we're seeing a kid with cough, and when we're seeing a kid in the AADC clinic, my approach is exactly the same, right? I want to know, how long has that cough been there? What does that cough sound like? Is there anything in the history that's going to help me determine whether this is a cough that's expected because the kid has a trach, or the kid has known GI issues, or this kid has CF. So, the answers as to why your patient has a cough is in the history 99% of the time. And I highlighted here and the guidelines make this point as well, that your approach to cough also is going to depend what part of the world you're in, right? So reasons for cough in my outpatient clinic here in San Francisco are going to be very different potentially than the common reasons for cough in East Africa, right? So you have to take that into account, obviously. And the important sort of where the road kind of splits is, if it's been there for a certain amount of time, it's either an acute and then it turns into a chronic cough. And that's key, that 4 week, if you look at the American guidelines, or 8 weeks, whether you look at the British guidelines, is I think most of the patients that are referred to aerodigestive centers really have a chronic cough. So they've been coughing for a month to 2 months. We're not seeing the acute cough. Acute cough is usually kids with colds, and the cough with colds can linger a few weeks. Those are not the kids that are being referred to aerodigestive centers. And so also from a pulmonary standpoint, it's important to us to sort of ask and probe, what does it sound like, right? Most of the cough that we'll see in aerodigestive center is a wet cough, but some of it could be dry. And then I put on the slide what some typical coughs of typical things that we know sound like. So, if you get a good history, you'll get the answer. So, but in terms of finding other reasons for cough, and this is a busy slide, but I put it up there to make the point that most of the kids we're seeing in our aerodigestive center really have a specific reason to cough, right? A lot of the kids we are seeing have feeding difficulties, have neurodevelopmental issues. A lot of the kids that we see here have had cardiac surgery, airway surgery. So these are the complicated kids where perhaps the cough guidelines as they currently exist do not apply. But for the next couple of slides, we'll talk about sort of kids that don't meet the criteria that you see on this slide, right? So if there aren't any specific pointers, if you've gotten a history and nothing really makes a whole lot of sense, then, first determine whether it's an acute or a chronic cough. Once you determine that it's a chronic cough, then is it a wet or is it a dry cough? That's sort of where kids are mostly referred to us, and oftentimes, depending on what we find, then we will refer them to the ABC center. But if it's a wet cough, we'll talk about what to sort of think about. For a dry cough, you put them on a trial of asthma therapy for 2-3 weeks. If things are not getting better, then you have to go look for other things, right? So if you've gotten to a point where there aren't any special clinical things that guide you, the next thing is you want to get a chest X-ray, and if they're old enough, you want to get lung function because that's oftentimes helpful. And assessing whether they have obstruction, whether they respond to albuterol is helpful to sort of guide you as to what the workup is or should be. So for that non-specific cough, the one that I think is important from an aerodigestive center is that wet cough, right? If the kid's been coughing for more than 4 weeks and it's a wet cough, the recommendations now is to give a course of antibiotics for something that we now identify as protracted bacterial bronchitis, which the group, Chang's group has really sort of looked at this. And there's just a lot of kids that are otherwise healthy, don't have any other concerning things, who just have develop a wet cough, and that's either they had an initial viral insult, and then they had a superimposed bacterial infection, but they're otherwise well. These kids, you can put on antibiotics for 2 weeks. If not improving, you put them on for 4 weeks. If not improving, then you should be thinking about doing a bronchoscopy. And at that point, these are a lot of the kids that are being referred to the Aerodigestive Center. And then there are a series of other tests that I think about and that we think about when we see kids in the AADC Center. If you have access to pheno, it's helpful. Chest CTs, skin testing. And obviously, I highlight the bronchoscopy because ultimately, all roads lead to triple scope in the Aerodigestive Center. And the part that we're involved in is the bronchoscopy. So this is 20 minutes from where I live in Santa Cruz. So I hope the weather is nice where you guys are today. So we've sort of talked about what a lot of aerodigestive centers do. We talked about why most kids are referred to aerodigestive clinics. And I put here I summed up what a lot of centers put in their reasons for referral. And so if you're thinking about creating an aerodigestive center where you live and you're thinking about whether you need a pulmonologist or not, I guess it's my sort of sell that look at all these reasons, and these are all pulmonary reasons, right? And so I put it on this slide, sort of what we're seeing in our center here. And I divided it into two because we see a lot of healthy kids with sort of chronic complaints, whether it's cough, whether it's chronic upper airway obstruction. So these aren't your chronically complex kids that are usually the kids that a lot of centers see or accept when they're screening patients. We want to be able to take care of everybody, right? And so I sort of say healthy kids with maybe asthma that's not well controlled, maybe asthma that has some reflux component that should be addressed. And then we see the kids that really have underlying issues, whether you're a preemie or you have a complex airway disease, genetic syndrome. So these are the kids that we and other centers usually see as well. And so what is my role, right? So when we meet before seeing our patients, we go around the table and we're all putting our sort of 2 cents into what we think is going on. And so what I do is, I try to get a history. I've reviewed the chart, and I have focused on the respiratory system because that's the input that the team is going to expect. I've looked at, have they've had chest X-rays? Have they had a chest CT? Do they have lung function? Have they had a sleep study? And if they haven't, are these things that I'm going to want to recommend to the team that we do before potentially saying, hey, we should scope this kid. And then the pulmonologist is, involved in, coming up with the plan, right? And like I said, we are the ones doing the bronchoscopy here. But that doesn't mean that the pulmonologist is the only one that can do the bronchoscopy. In many parts around the world, if you only have a surgeon, whether it's an ENT or a thoracic surgeon or a general surgeon, these folks can do bronchoscopies too. So this is where I say you don't really need me for the procedure, but I'm always happy to get invited, and I'm always happy to sort of get involved. And then, pulmonary always wants to be involved in sort of deciding when to see this patient back. And we want to know if we did a bronchoscopy, we want to make sure that we see this kid back. I have a couple slides in terms of bronchoscopies, because that's sort of our input. So flexible bronchs are different than what my ENT colleagues usually do. Most of the data, and this was published just this year, flexible bronchoscopies help in sort of make the diagnosis, either rule things in or rule things out. And if you're seeing a patient with stridor or noisy breathing, the flexible bronchoscopy is great to look at both the upper and lower airway. So oftentimes we'll have ENT kind of look at the upper and we'll sort of play in the lower airway. And most of the data that's published out there is, if you look, you find, right? And if you're seeing a patient with a chronic symptom that's not making a whole lot of sense, then it just makes sense to do the bronchoscopy. And the lavage obviously is helpful for us if there's a concern of a chronic infection, or if we still need really a window into what the cellular milieu of the airway is. The lavage is fantastic, right? And so these are, again, sort of common reasons for bronchoscopies that are published. And so from a aerodigestive center, we see a lot of kids that are referred for noisy breathing, stridor, recurrent infections, and of course, chronic cough. And so the lavage is important, right? Because you don't want to submit the child to a procedure and not get the data that you need. So, I put these things there. So if your aerodigestive center is just starting, I think one of the things that I would really focus on is make sure that you're best friends with your microbiologist. Make sure you get your pathologist involved, because you're going to be sending them a lavage, and you want to make sure that they're looking for the information that is going to help you make the diagnosis. So this is really, I think, the most important part of the bronchoscopy from a medical standpoint is we just need to make sure it's done appropriately. So when you're doing a bronchoscopy, where should you go get the BAL? If you have imaging, we'll go to where the abnormalities are. But if you have diffuse findings on a chest X-ray or on a chest CT, the highest yield lobes are going to be your right middle lobe or your lingula. Like I said, make sure your BAL, you get a total cell count, you get a differential, because that's going to help you tremendously. And so this is, I think, slide that's worth taking a few minutes to talk about. When you're doing your triple scope, there inevitably is going to be GI, ENT, pulmonary, and who's going to go first, who's going to go last. And I think it's really important as the pulmonologist to sort of, you need to sort of be heard because you want to make sure that you get a good airway evaluation. You want the patient spontaneously breathing. So you want to make sure that the anesthesiologist understands that you don't want the kid totally zonked, because if there's tracheomalacia, bronchomalacia, you're not going to see it, right? So going in, when I was a fellow 20 plus years ago, we did all our bronchoscopies through the nose, right? Because we wanted to see what the upper airway looked like. And if you are intubated or you have an LMA, your upper airway dynamic evaluation is not going to happen, and you're going to miss a bunch of things. The cool thing about the triple scope is if your ENT is going to look at the upper airway, if there's a plan to do a sleep endoscopy, they're going to be looking at the airway anyway. So most of our scopes today in our center, we use an LMA, but really think about what is the question that you have and what is the question that you need to answer. If you have an anesthesiologist who intubates the child, the dynamic eval is gonzo. You can't say anything, and the only thing you're really going to be able to say is, well, distal to the endotracheal tube, maybe the airway looks a little floppy, and you're going to be able to get a BAL, and that's it. So it takes a lot of planning. It takes a lot of time for a lot of the patients referred to aerodigestive center, and it takes a long time, and there's a lot of effort put into it. So if the kids made it to the OR, just there really needs to be communication between everybody on that right before the kid goes under. As a pulmonologist, make sure that you're heard. And sometimes people have different schedules and they want to go first. And so if pulm gets to go last, GI's done their thing, pulm's done their thing, and may not have looked at the lower airway, and then we're stuck there maybe for an hour before the patient wakes up. So it just takes a whole lot of planning. So that's why, I put that sign there. I had a sign that said stop, but I want to be welcoming. And so that's that. So from bronchoscopies are pretty low risk procedures. This is an older paper, but they looked at 1,400 scopes in their center, and the risk really are low. Only 5% of kids had sort of minor complications, which really have to do with either coughing or dips in their SATs. Major complications are TSATs with or without some of the things that you see here. And I think this is where having an anesthesiologist who understands what's happening in the OR that day, there are 3 surgical teams involved. It's a complex patient. If they're there and these things happen, I think that they take care of these quite often, and they do a really good job. So I think the risk of the bronchoscopy remains quite low. And so we previously used multiple use bronchoscopes that were used for years. Even most of the centers here in the US, and our center for sure, has moved away from the multiple use scopes to the single use scopes that you see here. And when deciding in your center, well, which scopes should I have? Well, if you are already using the multiple use, then and there's no intention or reason to change, and what you have works, then certainly continue. What the data shows is that the question here is really boils down to cost, right? What's more cost effective for the center? And what most of the data now shows is if there's high volume of bronchoscopies, then you're probably better off having the multiple use. But if it's a low volume center that you have, the single use is probably best. And it also really depends on what you have access to, right? So I think if you're in a part of the world where it's hard to get a multiple use, and it's not cost effective for maintenance and all these other things, getting it cleaned, then the single use is probably the better option. I find they're not as good. They're clumsy. It's not easy, but they will certainly do the job. And so the question is, what is the future for the pulmonologists in Aerodigestive Center with all the new interventional pulmonology things pediatric pulmonologists are doing, right? This is really, this field is in its infancy. And so I think that, if we're having this discussion 5 or 10 years from now, the pediatric pulmonologist is probably going to have a lot more to do than taking a look at the airway from a dynamic standpoint and obtaining a BEAL, right? Centers are doing endobronchial ultrasounds, cryotherapy. Centers are putting endobronchial valves and stents. So these are things that I think, if considering developing an aerodigestive center and you have an experienced pediatric pulmonology interventionalist, certainly they're going to be very interested in getting involved and helping you and helping the team get some of these things done. We currently we do a brush biopsy in our center right now, and we don't do any of these other things. So I want to sort of kind of close here with what are some secrets for a successful aerodigestive center? And I think I made a point early on is you really need to reach out to the referral base. Is you need to go out and talk to the pediatricians. You need to go to your intensivist, because these are where the aerodigestive patients are being seen, and this is really where they're being like where they're getting their trachs and where they're getting a lot of their surgeries. So I think here in our center we're still sort of knocking on people's doors and saying, hey, we have an aerodigestive center. It'd be really cool if you get us all involved at the same time when the kid is in the hospital for another reason. And let's perhaps think about how we can justify doing the triple scope while the kid is still here, right? So getting the people who are going to refer patients to you involved, I think, is key. A comprehensive pre-clinic eval, like we talked about, getting a good history, getting everybody on board, understanding what the patient's problems are, and more importantly, how the different systems are interacting with each other. So, is this really a GI thing that's contributing to the pulmonary complaint, or is it the ENT thing? It's really getting everybody on the same page. And I put here pro procedural team huddle, just because of what I said, is we want to make sure that even after we've talked about the patient on numerous occasions before going to the OR, it may not be the same team. So just make sure that you're getting in a huddle and knowing what needs to be done. And obviously following up and reaching out to the person who referred the patient to you is going to be key. So in the last couple of minutes, I will discuss an interesting case that we had just to bring everything together. This was a kid that we saw about a year ago now. He was initially referred to me. It was an 8-year-old. It is an 8-year-old with a chronic cough. He had been coughing since infancy, had been in the PCP and ER multiple times for cough, had several chest x-rays that were concerning, and had been on multiple rounds of antibiotics. So this is your typical kid with a chronic cough. It's a wet cough, had been there a long time, and really hadn't had a diagnosis, right? So when I saw him, part of the story also sort of revealed to me that he was coughing with feet, and he had a lot of ear infections, and he had seen an outside ENT for velopharyngeal insufficiency, and there was a concern of delay. So I referred him to our aerodigestive clinic because it just made sense that we all needed to sort of see this kid as a group. Parents lived far away, so it was convenient that if we were going to make him drive to San Francisco, that we were going to optimize their day with us. So we did see him, and I want to review some of the testing that we did. So we decided to do some of the things that we sort of talked about. Well, what's the pulmonologist going to recommend, right? So we did a chest CT, we did lung function, we reviewed some of the chest x-rays that the child had done before. And the chest CT had bronchiectasis, and he happened to have a right aortic arch with an aberrant left subclavian artery. And so further workup, and all these things didn't happen at the same time, but he then had an upper GI that showed an esophageal indentation. And then he saw genetics, and they diagnosed him with a type of DeGeorge. And I just wanted to quickly show you that some of the imaging, because I thought it was really cool. And this is the chest CT. And if you look at the esophagus, there's some there's some debris or there's something in the esophagus that shouldn't be there. And I'm just showing you some of the films, but you can see the right aortic arch there that's compressing the trachea a little bit. And then the bronchiectasis there. And then I thought this was a really cool picture. It looks like all this is in the trachea. But if you look at the lateral, it's in the esophagus. So something was going on in the esophagus. We knew that it was the aberrant subclavian artery. And this was the upper GI that will nicely show the indentation there. So, this kid's story really met all the things that we like to sort of think about in our aerodigestive clinic. And then this is the bronch, which our fellow did. And I'm just, the reason I wanted to show it is, and my fellow's talking a lot. I was trying to do the volume. So, but just to show you, I think we went in through an LMA, we put lidocaine on the vocal cords, and we sort of had a difficult time getting through, but eventually you'll get the tracheal lumen and you'll see that there's some compression right there, which we saw this on the CT. We already knew what the kid had. And so I'm not going to show you the whole thing for the interest of time. So we saw he had the tracheomalacia, which I showed you here. It took the fellow a while to get to the lower airways, but this child also had the bronchomalacia. We did a BAL, which had some moderate growth of oral flora. And GI found the esophageal narrowing, which we had seen in that upper GI. By the way, ENT's exam here was normal. So we referred him to the cardiothoracic surgeon. He had repair of his aberrant subclavian artery, the cough resolved, and then we had a very happy patient and grateful parents. But as a group, we felt really, it feels nice when all the efforts come together and you make somebody's life better. And so going back to sort of the puzzle that we had at the beginning, building puzzles are fun, and making them, connecting all the pieces is fun. It's interesting, and it ultimately helps patients. And so the key is, people need to be talking to each other. Everybody's voice needs to be heard and is important. And build a center wherever you are. You will help kids. And I think that's all I have, and have some times for questions.
Thank you so much, Dr. Ureggo. That was awesome and highlighted many really excellent points about the work we all do. Does anyone have any questions? For participants, you can put them in the chat. And while we're giving people a second to do that, I had one question, Fernando. You had brought up the importance of talking to the pulmonologists. I'm sorry, the pathologists when you do a BAL or a bronchoalveolar lavage. Can you talk a little bit more about that? Because I think this is something that comes up when I'm teaching residents both here and overseas. The importance of talking to other services. I mean, that's the whole sort of point of this lecture series, but I find that with radiology, if there's something specific that I'm looking for, making sure that they're capturing the right imaging, doing the right cuts, giving us the right data. I do probably less of a good job with this with that. I don't know why I keep calling pulmonology pathology.
Yeah.
And so I'm curious, I guess specifically for BAL, what are you asking of them? How do you approach that?
Yeah, so that's a great question, and it really is an important thing that needs to be done. So first of all, your pathologist needs to know that you're not looking for cancer, right? Because if you have an adult pathologist and they're getting a sample and they're going to say no cancer, right? So the first thing is to make sure that your pathologist knows that this is a child that cancer is very low on your differential, if at all, and that you're really interested in them telling you what kind of cells did you get in the lavage. We know what the percentage of cells that live in the airway. So we want a differential, right? We want to know, did we send them a lot of neutrophils? Are they seeing a lot of lymphocytes? Are they seeing a lot of upper airway cells? Did we give them a bad sample? We're also asking them to look for lipid-laden macrophages, right? And, we can sort of talk about how sensitive and specific are lipid-laden macrophages to whether your kid's aspirating or whether he's had a chronic infection, or what does that mean? But I think when you're looking at the big picture, when you're doing the bird's eye view of all your patients' problems, the more data you have, the more you're going to be able to connect the dots, right? So you want to make sure both your cytologists and your pathologists and everybody who's looking at the lavage knows the question, right? And the other important point there is that when I said make sure you speak to your microbiologist and just your lab in general, the specimens, if they sit in the drawer for a certain amount of time, you're going to start to lose data, right? So, buy your pathologist some coffee and sit down with them. Just like the point that you made, talk to the radiologist, right? From our standpoint, if we're getting a CT, we would love to have inspiratory and expiratory films, right? And then there's also a discussion, should we have contrast or no contrast? And so if we're submitting our patients that we've seen in our aerodigestive clinic to all these tests, we just need to make sure that bringing everybody else that's not at the table on board. So I think that was a long-winded, but it's just really there are more people in the aerodigestive clinic than just the ENT, the GI, and the pulmonologist, right? There are tons of other people that are contributing, and it's the aerodigestive center's job to put all that information together, right?
Yeah, thank you. I think that's a really good point. And it's a challenge, I think, in many hospitals to even just know who to talk to or how to call them. Do you have to walk down to the lab to talk to these other providers, or is it something you can do in a phone call? So I think for all of us, and myself included, I still navigate challenges with that when I go to different hospitals. And so
Yeah.
yeah, I think it's important to keep in the mind's eye, and yeah, it's a good reminder.
And the smaller your center is, the higher the likelihood that you know who to talk to, right? And like I've been at UCSF for a year plus, and I haven't met the pathologist yet, right? And we get calls from them oftentimes, and if we don't put in the order specifically, then we get a report, no cancer. That's not helpful at all. So
Fiona, I don't know if you're able to speak where you are. I'm happy to read your question if not. But Fiona has a question in this chat about the size of flexible scopes and any guidance you have on that. If they were to invest in one, like what would be a good size? And I think just for context, a lot of our participants are from places where resources are definitely very limited. And so thinking about if, it's tough with pediatrics because there isn't always a one size fits all, but I do think that there's a lot that can be done with less in a lot of cases. And so if you were to kind of guide on that and what you
yeah, that's a super good question too, right? So we currently are disposable scopes. We have the 2.2, the 3.2, and the 4.9. But if you only had access to one size, I think the 3.2, it could be a workhorse, because you can use it for pretty much anybody. And if you have a very young infant, the 3.2 will fit through an LMA. So those are the sizes that we currently use. The 2.2 doesn't have a suction port. So if you're using the 2-2, you're really just taking a peek.
Yeah,
Thank you. Sorry, I've stepped away. I have a follow-up question for you. Thank you, Dr. Ureggo, for this amazing talk. I kind of just wanted to know what you would recommend treating. So in the recent few scopes that we've done, we don't have pediatric pulmonologists doing the bronchoscopy, so we tend to do with rigid, or sometimes try to fuck with our flexible laryngoscopes to actually see if patients have tracheomalacia. So for dynamic airway obstruction in the lower airways, tracheomalacia, bronchomalacia, I am wondering what you generally would treat as, or what guidance you could possibly give to our setting where we don't really have a lot of home ventilation and things like that. How would you guide us to go about it?
Yeah, so most of the kids that we follow, or most of the kids that we've bronched that sort of come new to us, if they have tracheomalacia, bronchomalacia, if they're otherwise doing okay, depending on their age, we know that the Malaysia is going to resolve over time or become less of an issue with airway growth. So our approach for otherwise doing okay kids who just have a cough, and we go in there and they have significant bronchomalacia, we don't do any surgical intervention for most of our kids unless it's severe and it's life-threatening. Then obviously we refer to the surgeon for aortopexy. But most kids in general that I follow, time is the what I lean on. And then I tell them that because of the bronchomalacia that we saw, if your child happens to get a viral insult, the cough may last longer than if there was no Malaysia. And my threshold to put them on antibiotics, if I know there's significant airway obstruction, and I know if the kid's going to be coughing, they are going to pull a lot of distal airway secretions, then I'm more likely to put them on a course of antibiotics, right? If things are not getting better and this kid's having a lot of issues, then yeah, I think I would refer to a center that does sort of address these things. We don't do airway stents here. There are a couple centers that do, but it's not the go-to choice, and it's not a risk-free choice either. Airway stents migrate, they get granulation tissue. So you're trading one problem for another problem. So I think the tincture of time is what helps most of these kids. Now, if they're on if they have a trach or they're on some non-invasive ventilation, then we start thinking about, well, what is the ideal PEEP that these kids need to be on to stent the airway? But that's sort of how we approach them. And I hope I answered your question, Fiona. If not, let me know.
Yes, thank you. I have a follow-up question. Sorry, I seem to have very many questions.
Yeah.
Tracheostomy. Is it the pulmonologist that will follow the tracheostomy, or do you have like trache nurses that will follow up tracheostomy patients, especially the ones who are chronic users of the tracheostomy? Yeah,
so that's a great question. We're in the center where I was before, the trachs were ENTs, sort of under ENT's purview. They followed the kids with trachs. They took care of the trach. They were in charge of the trach. Here, we have a more sort of multidisciplinary approach, and really ENT and pulm, we have a trach vent clinic. So we have a clinic where we're seeing only kids who have trachs and vents, right? And we have our nurses that sort of follow up and make sure that they have what they need. And if there are any issues, our sort of staff does the triage, and then we'll let one of us know. So we have the luxury here that we have the team that has committed to actually having a clinic dedicated to kids with trach. So, which for me, after being in a different center and coming here, I'm like, wait, now we're supposed to be thinking about the trachs and we're supposed to be deciding these things. So it's fun to see both sort of how we can work wherever you are, right? One of our pulmonologists here who works on the other side of the bay, for example, they do trach vent clinic and there isn't an ENT there, right? And so she's scoping a lot of the kids in clinic. So we don't do that just across the bay. So things are really different depending on the zip code you're in.
Yeah, I think what we try to do in our multidisciplinary clinic is like if it's like truly just a trach problem, then that falls more on our purview. But if the kid's on a vent, then often it's like, Fernando, here you go, until they're off the vent, and then maybe it shifts more to ENT for the way we operate. And I had one follow-up question on Fiona's first question, which is there anything that you do leading up? So kids who perhaps have tracheobronchomalacia but aren't sick enough to need a trach or a vent, are there preventative like clearance things that you do or inhalers, other things that people may have at their disposal that you sort of try first line? And maybe that's you've already tried that because they have chronic cough, but could you talk a little bit about that?
Yeah. So it depends the age, right? So let's just say it's an 8-month-old who you're suspecting has tracheal bronchomalacia just because he sounds like a washing machine, right? But he's thriving and doing well and feeding well, then I still err on the side of possibly just monitoring, right? I think we do have options to assist with airway clearance. No, there isn't a lot of data on infants and kids on, should we be putting them on hypertonic saline and should we be putting them on albuterol? Or if we think there's a significant component of airway malacia, should we not use bronchodilators and should we use Atrovent? And so it's a great question, and it depends on if you ask 5 pulmonologists, you're going to get 5 different answers. I tend to sort of, if the kid's otherwise doing well, time will make things better, right? If the kid obviously, if you're suspecting has significant tracheal bronchomalacia and is in and out of the emergency room and has had chest x-rays that all look like they're having atelectasis or something in different parts and the kid's not thriving, then I may try some airway clearance. But if they're infants, it's probably not going to do a whole lot. I used to follow an older kid. I don't remember. He was a teenager. For whatever reason, he still had tracheomalacia that just didn't improve over time. And we had him doing acapellos and sort of some PEEP valve things that would, in theory, conceptually, physiologically, supposed to be providing some PEEP. But I think at the end of the day is, having that rapport with your patient, understanding how they're doing overall, and knowing that with growth, some of these issues tend to resolve in those otherwise healthy kids.
Thanks for bringing up an example I messaged you about literally yesterday.
Yeah.
All right, well, we're at the hour. I think we will, if anyone doesn't have any last minute questions, then I think we'll wrap up. Thank you so much, Dr. Ureggo, for this really excellent talk and a perspective from the pulmonology perspective. I know lots to think about here. And yes, if anyone has questions that come up, please feel free to message us through Mending Kids and we can always loop back. And otherwise, we'll see everybody in 2 weeks where the next talk will be held by our gastroenterology colleague and a pediatric surgeon who we work with on things like G-tubes and other more complex procedures that are beyond the ENT surgery scope. So
Thanks, Leah, and thanks for the invite.
All right. Thanks, everybody.